Welcome to an introduction to liquid biopsy, a non-invasive approach that acts as a new mirror for cancer detection and personalized care. In this talk, we'll explore how a simple blood draw can provide early detection, treatment monitoring, and genomic profiling, enabling molecular oncology decisions without invasive procedures and helping clinicians tailor therapies based on dynamic tumor biology. Traditional tissue biopsy leaves diagnostic gaps because of procedural risks, sampling bias from tumor heterogeneity, delayed imaging findings, and limited repeatability. The diagram here contrasts that with liquid biopsy, which offers serial systemic access, comprehensive genomic and phenotypic information, patient-friendly repeat sampling, and continuous cancer insights that can be applied throughout the care continuum to improve decision-making. Circulating tumor DNA, or ctDNA, consists of short tumor-derived fragments in plasma that carry mutations, methylation patterns, and copy number changes. Clinically, ctDNA reflects tumor burden for baseline diagnosis, enables minimal residual disease detection after surgery, and supports longitudinal post-treatment monitoring, providing an early, specific signal of relapse risk that complements imaging and guides timely intervention. Biomarker discovery from blood draws focuses on two windows into tumor biology: circulating tumor cells, intact malignant cells that provide quantifiable metastasis risk, and phenotyping for therapy selection, and extracellular vesicles, which carry RNA, proteins, and lipids as stable biomarkers, offering insight into the tumor microenvironment and enabling early detection and mechanistic studies. Liquid biopsy technologies span ultra-sensitive digital PCR for quantifying known low-abundance mutations down to sub-0.1% allele frequencies and next-generation sequencing for broad panels and whole genome discovery of novel mutations. Both approaches share critical workflow steps: careful plasma separation, molecular barcoding, and bioinformatic filtering to ensure analytical accuracy and reliable clinical interpretation. Isolation and analysis workflows vary by analyte. CTC enrichment can use size-based filtration or immunomagnetic EpCAM capture, followed by staining for cytokeratin, CD45, and DAPI with manual or automated enumeration, while exosomes are isolated by differential ultracentrifugation, precipitation, or microfluidic chips, and then profiled with RNA and protein assays to identify actionable biomarkers. Multi-cancer early detection combines ctDNA mutation, calls with methylation signatures, and advanced biomarker analytics to detect a broad range of cancers from a single blood draw. This strategy aims to shift diagnosis to screen-detectable stages with high specificity, low false positive rates, and the potential to direct curative interventions well before symptoms appear. For monitoring and treatment optimization, serial ctDNA tracking reveals clonal evolution and the emergence of resistant clones, think KRAS or EGFR, so clinicians can switch to targeted or immune therapies earlier. While CTC enumeration serves as a prognostic indicator of metastatic progression and helps guide decisions on adjuvant chemotherapy, intensity, and treatment stratification. In gastroesophageal adenocarcinoma, postoperative ctDNA positivity forecasts relapse months before imaging. Perioperative declines in CTCs correlate with pathologic tumor regression, and exosomal MIR92A has emerged as an early diagnostic aid that supports neoadjuvant decision-making and informs surveillance scheduling, together enabling more personalized perioperative management. Applications in colorectal and pancreatic cancer show complementary strengths. ctDNA MRD detection after colorectal resection offers higher sensitivity than standard CEA monitoring and helps guide selective adjuvant therapy and early recurrence prediction, while pancreatic cancer benefits from combined KRAS ctDNA analysis and fragmentomics on integrated platforms to boost diagnostic yield and adaptively monitor therapeutic response. Moving promising assays into routine clinical use requires standardization across the entire pipeline. Harmonized pre-analytical collection and handling, certified reference materials for performance benchmarks, interlaboratory ring trials for comparability, and AI-driven quality control for real-time monitoring. Together, ensuring reproducible sensitivity, specificity, and clear clinical decision thresholds across hospitals. Integrating liquid biopsy with multiomics combines longitudinal ctDNA data, radiomics, proteomics, and electronic health records into a machine learning predictive engine that produces recurrence, therapy response, and survival predictions, enabling adaptive trial designs and truly personalized oncology care, where treatment plans and clinical trials are tailored to dynamic, data-driven risk models.